Alright guys, welcome back. Hope you had a good break. Getting back started. It is Monday, the 18th. Back in the saddle, ready to go. We're going to start with gynecological emergencies. It did fall under the medical emergencies, but I felt that it was better to put this in with the obstetrics portion as well and tie them together and wait. Give you guys like one less chapter I have to deal with then, but unfortunately got to pick it up now. So here we go. Alright, I'm going to give you a warning. There are pictures of penises and vaginas. There's no pictures of coitus or intercourse, but we are adults here. We're learning about anatomy and how it functions. There are pictures of penises and vaginas in this presentation, so I'm warning you now. But again, we're all adults, and it's the only way really to show you some of the STIs and what they look like, so you're prepared for those. So you have been warned. Alright, usually I skip this slide because it's pretty much the same thing in every PowerPoint. Gynecology. Gynecology is the study of the vagina and the process of what a woman undergoes, usually in her monthly cycle, and STIs and everything of that nature. Now, I will give you a caveat to this. I have a disclaimer. I'm not a woman, so I cannot give you any examples. I can't empathize. I can't sympathize. Nothing. So I can pretty much just be a guy, a man, telling you about things, but unless you're a woman and experience this, I have nothing to give. Usually in most chapters, I have something to give. I've done something stupid for shock trauma and have bled before or seen it. For this, I've got nothing. I've actually, in my 12-year career, have not birthed a child, which is very uncommon, very unheard of. So, that being said, I probably jinxed myself and it'll happen tomorrow on shift. But, anyways, back to our topic at hand. A lot of the stuff that we're going to cover is going to be vaginal bleeding. A lot of it has to do with infections, STIs, as far as a medical emergency for a woman. We do have sexual assault in there. That is a very serious, delicate matter, and it needs to be handled very gingerly and very delicately in order to preserve evidence. If there's any evidence left to be preserved, we'll talk a little bit more about that when we get into it. Injuries and bleeding usually comes from either STIs. There's a normal menstrual cycle a woman goes through. Typically it's 28 days. That's not always the case. We'll talk about that as well. There's stuff for vaginal discharge. There's different colorations for the vaginal discharge. And there's the STIs I talked about. We'll actually go pretty deep into STIs. So I'm not going to hold you to all the STIs, but if I probably pause and kind of stress some things, you probably want to pay attention to those. Some anatomy and physiology. We're going to go over these, hit these up pretty hard and heavy as we go over the next few slides. We have the vaginal cavity itself. There's the vaginal opening. We will kind of discuss about that. I'm not really truly worried about the vaginal opening and the exterior of the vagina. What's really truly important is the actual vaginal cavity, the cervix, the uterus, the fallopian tubes, and the ovaries. That's what I really want you to know and hammer hard on, because those are where the places that things can go wrong the most. Also, when we get into obstetrics, and if for those of you who don't know what obstetrics means, it means birthing babies. It plays a key role in how this all works. We'll talk about the menstrual cycle here in a little bit, and then how that's going to play a role in what's going on as far as the baby and how the baby implants into the uterus and etc. I do want you to pay attention to this side over here. If you'll look, it's just not all nice flat up and down. It's actually, you've got the vaginal cavity that goes up and in. You've got the cervix, which is the opening to the uterus, and then the uterus actually kicks back up and over. So it's not like it's just the vaginal cavity and the uterus and everything is just right there. It's actually up, in, and over. So that side view is very important to me, because I want you to realize how this works. Especially what's really important is when the uterus has a baby inside of it, and basically when a woman is pregnant, and how that affects the rest of the body, which we'll go through in our next chapter, obstetrics. Start with the ovaries. Ovaries are where eggs are produced. They are called oocytes. Yes, it's exactly as it sounds. Oocytes. Usually an oocyte will meet up with a male sperm, typically in the fallopian tube. Believe it or not, sperm does go all the way back into the fallopian tubes and typically fertilizes an egg there. And it'll implant somewhere in the uterus if the timing is right, and it'll implant, and a baby will be born. But we're not going to get that far. But we're going to kind of talk about it, touch on it a little bit more as we go. The estrogen is also, and hormones estrogen and progesterone are also produced from the ovaries themselves. This is where the eggs are stored. Now we're going to get into the fallopian tubes and the travel that, or the path that the oocyte travels. So you have the egg actually matures and gets released up and out into the fallopian tube. One of the things I want you to understand is that the fallopian tubes are not encapsulated or do not wrap around the actual ovary itself. So we're going to talk about something called ectopic pregnancy. So it is possible that an egg can be fertilized outside the fallopian tube if the egg is not released into the fallopian tube. It does happen. It won't grow because there's no lining for it to attach to and grow, but it can attach and grow inside the fallopian tubes if it doesn't travel through the fallopian tubes into the uterus. So that's just something to keep in mind, that the actual fallopian tubes wrap around. They're close to the ovary, but they actually don't touch. So it is possible that an egg can actually be released outside the body. It doesn't happen, it has, but it's actually not common. It's actually just the opposite. But I just wanted you to keep that in mind, that they're not touching. So the egg's released from the ovary. It goes into the fallopian tube. If it is to be fertilized, it usually happens inside the fallopian tube, and then it makes its way into the uterus. Now, the uterus is where all the magic takes place for the implanting of the egg and the growth of a fetus. What happens every 28 days is that a woman will build up something called endometrium. We'll talk about, there's a condition that can happen with endometrium called endometritis. The endometrium builds up, and if a egg implants, hormones are released, and it winds up being that the baby will grow. If not, then the woman will shed the lining, and it'll come out as bleeding, vaginal bleeding, and it's her period. And they call it a period because the cycle is typically on average 28 days. That is also not the case. It does not happen that way. But usually a woman is on some sort of cycle, typically. Usually not at first. When they have their first, it's called menses. When they have their first menses, or their menstrual cycle, it's not always regular, but it eventually, as they get into adulthood, it does become regular. Some women do not have regular periods. They are few and far between, or some women actually suffer 21 days cycles. It all just depends. So also the uterus also helps squeezes the baby out of what will go into the vaginal cavity and through the cervix. We'll talk about that more as we go, but the uterus is very thick, very strong, and muscular. And so when it's time to birth the baby, it helps squeeze the baby out and down through the opening. The vagina, or the vaginal cavity, is where, obviously, where the male penis goes in, and the sperm is released into the cervix. The cervix, real quickly, cervix is the area of the uterus that is the opening of the uterus. It's pretty much inside the vaginal cavity. If you can see this diagram right here, all this right in here, this is considered the cervix, even though it's still a part of the actual uterus itself. This is called the cervix, and that is where the sperm will enter and travel, and usually go up in the fallopian tubes and go ahead and fertilize the oocyte. I think it's really funny that it completes the passageway from the uterus to the outside world. It is for delivering the infant. Again, like I said, it accepts the penis for fertilization of the oocyte, and it's basically the gateway in between for the baby and to hold the penis. There's a bunch of stuff. I did want you to just kind of see some relative stuff. There's the bladder in relation to that. There's your fallopian tubes, your ovaries. There's the uterus, the cervix, the vaginal cavity. This is the outer layer of the vagina there. This is the anus and rectum right out here, and then you have the anal sphincter. Up in here is also they've got the urethra. So I just kind of wanted to give you like a relative area of how that's all built and designed. Not going to hit too hard on the external part of the vagina. I'll just know that it's pretty much there to seal and keep the actual whole entire workings of that isolated and protected pretty much from bacteria getting up in there. Women are more prone to having UTIs, typically from fecal material and also from intercourse. It does happen. I'm not going to really hit this hard, guys. It's not what we need to really worry about. We're worried about the actual internal workings. Again, we've already kind of talked on this about menstruation and how it's cyclical for every 28 days. Again, I'm not a man, but I do have a daughter, and let me tell you that it is not as always as regular as it sounds. So one of the key phrases I want you to pay attention is menarche. That is the first period a woman, or I guess sometimes it'd be a teenager, a younger woman has. Menopause is actually when it stops. Typically, it's usually early 50s, late 50s, somewhere around in there for a woman. So you think about it, it's going to be 35 to 45 years that a woman will have a menstrual cycle every month. There is medication like birth control that they can actually stop that. It releases hormones to make the woman think, or her body, or trick her body into thinking that she's already pregnant. So they give the little low dose hormones, so the menstrual cycles will stop, and they do obviously cease and desist when she is pregnant. So that's how birth control typically works. At least the oral medications. I know the intrauterine goes into the cervix and tries to block sperm from coming up that way. So there's different ways to actually have sex without risk of pregnancy. There is something, and I know it's actually kind of a stigma, women who have PMS, premenstrual syndrome, and it winds up allegedly makes them overly emotional, from anger to crying. I really don't buy into that. It could be other factors as well, but typically they do have some sort of bloating and cramping before, like either a week or 2 weeks before, typically during ovulation, and it usually, because they usually ovulate a week or two before, and the egg will start coming down, and then it'll be set up to implant into the uterus. But some women actually have it really bad. If I'm not mistaken, the next slide, it shows the period and the flow and the days and stuff like that. How it builds up. We'll talk a little bit more about that, I think, as we continue on. But middle schmerz, it's experience intense abdominal pain, like cramping. I don't want to tell on my daughter, but she does kind of suffer a little bit from this. Like, it's very severe, intense cramping. She usually gets it about a week beforehand, and she's just in agonizing pain, but she's tough, and she suffers through it, and she gets out there and still works with the best of them. I gotta hand it to her. I give her props. But it is abdominal pain. It's usually localized to one side. In ovulation, which is the releasing of an egg, typically it's one egg, and it rotates every other month, obviously, or every month it will rotate. Which side? There's two, obviously, of the ovaries, and it'll rotate between sides every month. Sometimes two eggs are released. I'm not exactly sure of the pathophysiology of how you get fraternal twins. We can probably ask Winkles. Maybe he's looked into this, or he'd like to write a report on how this happens. But there's one-sided pain. Sometimes a woman can tell when her egg's been released because she can feel it. It is somewhat painful. So, but there is the excessive pain and cramping with PMS. It's called middle schmerz. Amenorrhea is actually the absence or cessation of blood flow, and basically it happens typically in the younger teenagers, but it can happen to a woman who has a normal cycle. It's really stressed or exercised induced. It just has to do with the imbalance of hormones. Stress will definitely imbalance your hormones. You remember we talked about the stages of stress and how you can last for a while and then all of a sudden you crash. But with that being said, the amenorrhea, basically the A meaning the absence of the menorrhea, which is the flow of blood or the menstrual flow of blood. So it can usually happen. It happens. Vaginal bleeding. So let me just go ahead and say that if you have a woman and you're called out for vaginal bleeding, you could probably ask and try to get a good history, but you probably may or may not really be able to find out what's going on. Vaginal bleeding and pregnancy, especially in the third trimester, that's a huge concern. Vaginal bleeding can be a lot of things. I'm not saying it's not an emergency, but what I am saying is it could be anything. And you could try to do a good history on a patient, and they just may not know what if they've had unprotected sex. Okay, but that may or may not be the cause. They may have an STI. Okay, that may or may not be the cause. Vaginal bleeding is a big canvas when it comes to certain medical conditions. So when coming to gynecology, so we really don't know. So when you get called out vaginal bleeding, try to get a great history if you can, but just do your best. If you have to, you can probably use like trauma pads or pads to try to control the bleeding. The one thing I'm going to tell you right now, there are only I think 1 or 2 conditions, and it has to do with birthing a child, that should anything in your ambulance, including yourself, be put into the vagina. Nothing should be put into the vagina. Let me stress this. Nothing is put into the vagina. Nothing. You do not pack the vagina with gauze and try to control bleeding that way. Nothing. You can do external pressure. I've done that before. You literally will hold a trauma pad or a pad of some sort, and in the most gentle, polite, non-sexual manner, hold it and press it. If you can get the patient to do it, fantastic. But if you have to hold it and press up against there and try to control bleeding, what you're trying to do is you're trying to get that blood to flow into the area where it's bleeding and form a clot. If blood is moving, it's not going to clot. So you've got to get it to stop moving and to form a clot. So, but again, do not pack the vagina. Like I said before, third trimester bleeding is a very serious emergency. We will go over why in our next chapter when we go over obstetrics. If you have vaginal bleeding with trauma to the abdomen, obviously there's a possibility for an issue. There could be a tear, or there could just be significant trauma that affected the actual vaginal or the cervix or the uterus itself. So vaginal bleeding is a very big deal, but especially in pregnancy. We're going to talk about some of these things here as well. We're going to talk about, it says acute or chronic infections. What we're really talking about are STIs. Hemorrhage, bleeding is bleeding. Like I said, you just basically try to just take a trauma pad or some sort of pad and hold it or press it up against the vagina the best you can for the outside. Nothing goes inside. You can be called out for a ruptured ovarian cyst. We'll kind of talk about that. And really, ectopic pregnancy is kind of a big deal too. So we'll also talk about what that is and how it works. So the first thing we're going to talk about is PID, pelvic inflammatory disease. It has to do with infection that has to do in the uterus and the fallopian tubes. This is your book's definitions and what they have. I kind of added to it. It has to do with bacteria spread into the vagina to the uterus or the fallopian tubes or onto the ovaries itself. So you're going to have some sort of infection, inflammation, and it can only be treated with antibiotics. It's bacterial. It's going to grow in there, and it's going to only be treated for that. One of the telltale signs for this is abdominal pain. You'll have vaginal discharge. You may have bleeding as well. Pain during and after intercourse. If you have pain, or if there's pain from your partner, if you're a guy, woman, females, if you have pain during intercourse and you have abdominal pain and you have some vaginal discharge and some bleeding or some light bleeding, and it hurts to walk. One of the things that I also will put in there was the PID shuffle. People don't take just normal steps because stepping down and jarring your body, because when you do take a step, it does jar your body a little bit. That is painful. And what they call is called the PID shuffle. And they basically, women, you'll see them, they'll just shuffle their feet. And that's kind of how you know that it could possibly be PID. And again, it's just bacteria that's grown in the uterus, the fallopian tubes, or on the ovaries, and it can only be treated with antibiotics. And again, it's bacterial. Kind of a diagram of where it goes and how it can spread. If you're going to treat them in an emergency, patients are usually doubled over and can't walk. Like I said, remember I said walking is very painful, and having to walk is very difficult. It hurts. They may be running a fever. Again, bacterial infections, they will cause fever. Put them in a position of comfort. Get the stretcher as close as you can, and just take them to the closest nearby facility that does have some sort of gynecological emergencies that they can handle. STIs. We're going to talk about a bunch of them. I'll show you what I really want you to remember and what I don't want you to remember. For vaginosis, typically with vaginosis, there is an odor. There might be some itching, burning, pain, but really there might be an odor and some smelly vaginal discharge. I really don't know if it's painful or not. I wish I could tell you, but I really think it's the odor and kind of the itching and the burning that make it so it's very noticeable. One of the things that I will say that there's something called a yeast infection, so it could be confused with a yeast infection, because yeast infections, and I'm kind of stealing my thunder, we'll talk about here in a minute, is also itching and burning as well. But really it's the smell. That's how you kind of know if it's a bacterial vaginosis. It has an odor. So, hint, wink, wink, nudge, nudge. I kind of put some extra information in there for you. One of the things, since we are talking about vaginal discharge, believe it or not, the vagina does discharge. It does happen. Sometimes it's clear, it's normal. It can kind of happen. It happens. And unfortunately, again, I don't have a vagina. I cannot relate. But red is definitely blood. Pink is there's some mixture of blood with a normal discharge. They're saying the gray, if you have kind of a gray, it's the bacterial vaginosis. White is also considered healthy, but also for yeast infection. Yellow and green usually is your STIs. So that's kind of how you can kind of break that down. I'm not going to hold you accountable, but you do need to know red is blood. Here are some cancroids. So it has to do with some bacteria that is growing on the outermost portions of the genitalia, and it causes painful sores and ulcerations. It's caused by that bacteria there. I don't know. I'm not going to try to say that word, but those are cancroids. Chlamydia. It's also an STI. Hopefully you've had a sex ed class. Again, in women, there's discharge from the vagina. There's bleeding, burn, and pain upon your urination. That's, I think, kind of the telltale sign that if you do have burnful, painful urinations, that's going to tell you that it might possibly be chlamydia. Also, with the frequency of urination being elevated, you have to pee more often. That might also gear you to think that it might be chlamydia. Cytomegalovirus, CMV, it's part of the herpes family. The real reason why you want to know what this is you want to know this is because it affects children and can be passed on to children. Prolonged high fever, headache, malaise, which is basically just extreme fatigue, laying around. There is an enlarged spleen. You will not be able to probably diagnose that unless it's just blatantly obvious with an abdominal assessment. But again, it's in here. It's in your book. I threw this in. It kind of affects how you try not to give it to children. This is actually really out of Britain. A lot of the things I found were British, and they're trying to stop the spread of CMV. Another herpes that we talk about is actually just genital warts. Obviously, it's passed from one open sore onto a break in the skin somewhere. Believe it or not, you can get breaks in the skin during sex. I know that's hard to believe, but it does happen, and that's why it's in the genitals, buttocks, or anal area, because those are areas of sexual intercourse. The virus is broken up to herpes simplex 1 and 2. Typically 1 is like your canker sores. So like if you've got a canker sores, I know it sounds horrible, but you have herpes. But that's simplex 1. The genital warts that we're talking about is usually simplex 2. So there is a variation between those two. So for herpes, simplex 1 are usually canker sores found on in and around the lips, believe it or not, or on the face. I've actually had one on my chin that was huge, and I thought, oh my god, I have herpes. And the doctor had to sit down and explain it to me, like, nope, pretty much everybody has simplex 1, because if you've kissed anybody and you've had chapped lips or bleeding a little bit of blood or whatever, you've passed it around that way. The simplex 2 is sexually transmitted, and that's why it's in the sexual intercourse areas. Gonorrhea, it is also an STI. It's bacterial in nature. I don't know too much about this other than it's there. It does have a greenish yellow or white discharge from the private parts, also for men as well. So abdominal pain, you could have some vaginal bleeding. They talk about like the swollen glands in the throat. That usually does come from oral sex. So I don't know much. Like I said, don't know much about this, but it is bacterial, and hopefully, I believe it's treatable. We did talk about genital warts, which is the HPV, common STD. You may not have any symptoms, but you may still have it. So there you go. They do have a vaccination now out for HPV. They started giving to the generation now that's teenagers. That's been going on for about 5 or 6 years, because I know my children have gotten it. So other than that, that's all I really know about that. Alright, there is another disease called syphilis. Really, what I really want you to pay attention to on this, for syphilis, it's a bacterial infection. It's from that bacteria, this one here, not even going to try it, but there it is. That's the bacteria that causes syphilis. It is a sexually transmitted disease. The problem with this is that it has 3 stages. 3 stages, and we're going to talk about them more. I've got a diagram for you. The first stage, or the primary stage, is usually lasts a couple days to about a couple months after exposure, and it has to do with sores or ulcerations around the genitals. So those typically will heal. And most people are like, okay, maybe it's a cancroid or something like that, whatever, it went away, woohoo! And then several weeks later to a couple months later, you have the secondary stage, which they're calling here stage 2. And that is an all-over body rash. Now, that should be your sign. Here's your sign. Like, okay, I've had a cancroid or cancroid-looking ulceration. Okay, now I have a body rash. This is not good. But there's some dormancy. It'll go dormant before you have the all-over body rash. There is a tertiary stage, also known as stage 3, and it will attack your internal organs, and it will slowly make them so they don't function as well. So this is called the tertiary stage, and this could be years, months to years later. And once it gets to this tertiary stage, it starts affecting your organs. You can't really undo it anymore. There's treatment to a certain point, but you can't have the treatment past a certain point, because by the time it gets into your it'll affect your brain, your heart, your liver, and start shutting these organs down. You're dying. So usually the key is that you've had an ulceration in and around your genital area, and then you have an all-over body rash. That's when it's time to figure out what's going on. And typically, hopefully it's caught before then. I cannot say this, but I'm going to try trichomoniasis. It's a protozoa. Remember, all the things we were talking about have been either viruses or bacteria, mostly bacteria. But this is a protozoa, which means this is a living, individual-celled organism, and it exists on its own. It can also be an STI. I can't have to be honest. I don't know much about this either, but it's there. Again, the real thing, just know that it's a protozoa. That's what's different about it. Yeast infections. It is caused by a fungus, and typically it's treated with over-the-counter antifungal yeast infection creams like monostat cream or something like that. And basically, it has to do with the acidity, where the yeast will overgrow, like the acidity somehow is lessened in the vaginal cavity, and it winds up with itching, burning, and again, it's just treated with I believe it's Monostat is one of the major name brands. I don't know. Again, I apologize. I'm not a woman. I have not had to deal with any of this, and I feel bad for those that you have. So, but that's yeast infection. It is a fungus. A yeast infection is a fungus. So, during ovulation, sometimes cysts can form on the ovary. I don't know why they happen to form, but they'll fill with fluid, and when ovulation happens, due to the way the egg literally will kind of rupture out of the ovary. It will literally it starts here, and then the egg kind of forms up and through, and then it ruptures out into the fallopian tube, and that's what gets it into the fallopian tube. But it'll rupture through the cyst, or it'll be through the cyst. And women have these, and they're actually very familiar with them. Sometimes they have them every time they have their period. I don't know why they're caused, but some can get very large and be very painful. And when they rupture, they do hurt. So you may be called out for something of that nature. Sometimes women will know that they have them and have a history of them, and sometimes they don't. So it's just kind of how they know and what they know. Again, it can rupture. It'll be one-sided pain. Typically, it forms on the side that's going to have the oocyte come from the ovary into the fallopian tube. There might be some bleeding associated with that, but it might be just pain. But really, the telltale sign for this is it's one-sided pain. Like PID, it'll be abdominal pain. You'll have the shuffle. Some of the STIs will be just kind of localized pain, where the PID is global. But this will be unilateral pain. It'll be pain on one side. So that's how you'll know it's probably an ovarian cyst, and it usually hurts, then it ruptures, and then usually when it ruptures, it hurts for a little while, but from what I understand, the female population that I've been around that has explained it to me that, yeah, once they rupture, it actually feels better. So I guess once it's ruptured, it's like, oh, thank God. So that's what I understand. I don't know. Again, I apologize. I do not know, and if I'm wrong, ladies, please correct me. Ectopic pregnancy. Let's go ahead and show you. Basically, like I said, the egg gets released from the ovary. The oocyte is released into the fallopian tube, and it gets fertilized in the fallopian tube. Typically, what happens is that sometimes women have scar tissue, something that blocks fallopian tubes, or it may implant before it gets to the actual uterus, and it'll start, the fetus will start growing there, and there's usually associated pain with that. The part where it's bad is that when it grows to the size where it bursts open and ruptures the fallopian tube, or where it's not supposed to be. You can have it on the outside, an abdominal pregnancy. I have never seen one. Usually the ones that I see, they do say it's in the ampullary area of the fallopian tube. But yeah, usually I see them, if we're going to have ectopic pregnancies, they're typically in the fallopian tubes. If it's in the cervix, I believe a woman will just typically miscarry from there. That might be part of a miscarriage. But again, I'm not an expert. If it does rupture, they might present with hypovolemic shock. We haven't gotten into that, but that's usually pale, cool, diaphoretic skin, tachycardia to a point, and then bradycardia when they're crashing. And they will be hypertensive a little bit, but really they'll go hypotensive very, very quickly. So a good history, because usually the bleeding you can't see is the one you need to really worry about. All the bleeding that you can see, you can probably stop some way or another. If it is, especially on the extremities, we'll get into that when we get into shock trauma, but really you need to look for pregnancy or ectopic pregnancy, or consider it. One of the things that you also need to consider is from the age of 9 to 90. Age 9 to 90. You might want to consider that there's a possibility that they can be pregnant. I'm not saying that 9-year-olds are sexually active. There is also something called sexual assault. That does happen. So, especially nowadays, young girls are developing into their secondary sexual characteristics, which is basically puberty, a lot sooner than when I was a kid. 20 years ago, it wasn't uncommon for a 12, 13-year-old to start having puberty, but now it's getting on into 12, 11. So the rule of thumb is 9 to 90. Now, please do not ask a 9-year-old, are you sexually active? That's just horrible to ask. They're not going to know. But you kind of have to keep that index of suspicion in the back of your mind that might be a possibility. So if the ectopic pregnancy does rupture the fallopian tube, or the area in which it is implanted, that is a true emergency. Surgery is now required. So if you have a suspicion that it might be a tubal pregnancy, they are called tubal, or an ectopic pregnancy, consider taking them somewhere that has surgical intervention. They say all sorts of reasons for ectopic pregnancy. It could be an intrauterine device, basically where you place a piece of plastic that releases hormones in the cervix, in the opening to the uterus, to try to kill sperm. Tubal litigation means there are scar tissue in the fallopian tube itself. PID, that's pretty bad. As we talked about before, the bacterial growth and stuff like that. So there might be inflammation and swelling there. There could be a previous surgery. So again, if the pregnancy is not cotton time, a woman may not know she's pregnant. She may or may not, or she may not want to accept it. Usually you don't really test till 4 to 6 weeks after they're being pregnant. And by that time, in that limited space in the fallopian tube, that fetus implanted, it's going to be growing. So they may not know. Vaginal bleeding, it's kind of a catch-all. Again, like I said, it could be a number of things. All the things we just talked about can be vaginal bleeding. Again, third trimester is bad. Color differences, if you're trying to tell if it's bright red blood or if it's dark red blood, it may be kind of hard to tell. Bleeding is bleeding. Again, don't pack the vagina. Try it, if you have to try to control the bleeding, put pressure on the exterior of the vaginal cavity, on the outside of the vagina, and pack and hold, try to get a clot. You can do that. So many reasons why there could be vaginal bleeding. And we've all just pretty much talked about most of those. One more thing that I want to cover that kind of is going to segue us into, along with the ectopic pregnancy, will segue us into obstetrics, is endometriosis. So it's treated with antibiotics. It's caused by some sort of infection, STD. But what it really is it is the endometrium is the inner layer of cells inside the uterus, and it is what kind of builds up and prepares to receive the egg or the fertilized oocyte, and to allow the baby to start growing. It's all inside the uterus. Now, it can grow and continue to grow outside of the uterus. It can happen, obviously, because everything's linked. The fallopian tubes to the uterus, to the cervix, to the vaginal cavity, it's all linked together. So it can happen. The endometrium can go all the way to the fallopian tubes, to the vaginal cavity. It is just an excessive growth of that, because the body grows it. A woman's body will grow and get ready, and it builds up those cells, that endometrium, and it could just get a ramp up in growth and keep growing outside of the uterus. So endometriosis is the condition of that. So it's part of infertility in women. Like I said, it can the tissue grows outside of the uterus. It is painful, but there may not be any signs and symptoms. And it can grow anywhere. It can grow up into the fallopian tubes. They say it can go out. I'm at a loss of how that happens, but it does happen. It can just continue to grow in other places that it shouldn't. Now remember, the endometrium is what's shed every month. It gets shed and it builds up that layer, and it builds up and it builds up, and it gets a lot of thickening and blood to that area, because if it does implant, it's going to need a lot of blood to that area as it builds up and starts getting the placenta to start feeding and giving nutrients and oxygen to that child. So the blood buildup is all for naught usually. So for considering how many times a woman actually has a menstrual cycle versus how many times she's actually pregnant. One of the things that we will talk about, and I will talk about this again because this is kind of a concept you have to grasp. So there's something called eclampsia. And what it really means is that there's a chance that a woman can have extreme hypertension and actually suffer from seizures and actually slip into some sort of coma due to the hypertension. So that's what eclampsia is. There's preeclampsia, there's eclampsia. Those two are while the mom is pregnant. The difference between preeclampsia is she's hypertensive, she's prone to the risk. As soon as she has a seizure, it's known as eclampsia. Now she's eclamptic. And then postpartum eclampsia, believe it or not, it just doesn't go away. It's not like gestational diabetes, which we'll talk about, I believe, next chapter. Because you can have diabetes when you're pregnant, and it goes away as soon as the baby's born. But again, you have preeclampsia and eclampsia while they're pregnant. The difference between the two is when she has a seizure. She'll also be very sensitive to light. Like, light will literally bother her eyes. She won't be able to be. She'll have the room dark. She will not want bright lights in and around her. She will be very hypertensive, very lethargic, and postpartum eclampsia. It can happen. I've actually ran a patient. I was actually an EMT, so I really didn't know what was going on until I hit a paramedic school, and I was like, oh my god, I know exactly what that is. So sometimes it takes seeing things. But that being said, it could be up to 6 weeks. 6 weeks. So what the predispositioning factor was, if she had preeclampsia, she could probably have postpartum eclampsia as well. And if she actually suffered from eclampsia, again, which is the seizure, she's at risk for postpartum eclampsia as well. It does happen. All right, sexual assault. Let me just go on record and say that usually, I believe the CDC said it is 1 in 7 or 8 people, not just women, but people, will be sexually assaulted. Those are reported cases. I will go and say that I'm sure that it's probably more. And it is very sickening to think that we live in a world where sexual assault might possibly be prevalent, but it's there. And I don't have an answer for it. So if you've been sexually assaulted and this bothers you, I do apologize. But it is something we want to talk about because our job, we will meet and encounter people that have been sexually assaulted. It is not for us to investigate. We do not need to see the vagina. The only time you really need to see a woman's vagina is if she's pregnant and she says she's in labor or her water broke. If a woman's pregnant and she says she's in labor, whether she's having Braxton Hicks, which is false labor or not, you better have those panties off, and you better had somebody look to make sure she's not crowning. Men, you need to get comfortable with that. I particularly like to find a female that's on duty, and if I do have a patient that does have some sort of gynecological or obstetrical complaint, I usually like to take them with me and let them look and visualize for me, and then go from there. Again, like I said, I've never birthed a baby, so I'm not prone to be that shit magnet. So, really, again, sexual assault, have compassion. Try to urge them to go to the hospital. They do have a rape kit where they can extract DNA. Try not to let them shower. Unfortunately, we kind of fall back into, if they're alert and oriented ×4, they can kind of do what they want, but really try to have some compassion and really tell them, hey, listen, we need to catch the person that did this to you. We need their DNA. And it all really depends on the damage that was done. If it's not consensual sex, there's probably more trauma done physically, obviously mentally, but physically done, than just to the sexual or to the sexual reproductive organs. So we need to make sure and treat that. There could be choking. People could be tied up or held down, and it's sad. So we have to treat the entire patient. It will probably, as for a male provider, it's very probably, especially if it's a female that's been assaulted by a male, you may have to call in another female if your service has one to try to assist with that, because they may be afraid of a male, especially one they don't know, especially if they've been raped by someone they didn't know, which is, believe it or not always the case. There is a pattern of rape typically has to do or happens with people who are very familiar with each other, or at least know each other. So again, sexual assault is a big deal, and really treating these patients, we have to tread very lightly. There's things to consider as far as you may not be dealing with just an actual common rape. There can be other things involved as well. You might stumble upon some sort of controlling or controlling person or someone's been controlled. There's something called, we won't get into it, but the Stockholm effect, where people have been kidnapped and then they start relying on their captors and start viewing their captors as people that they will defend. It sounds really weird, but be professional. If you do have to do a physical exam, if there's bleeding or significant bleeding, please keep it brief, be short, be courteous, and try to just kind of think how you would want to be treated as well if you were in that position. Again, we do talk about preserving evidence if we can. So if you've got to cut clothes, try to cut and save. Do not put in plastic bags. Put in paper bags. Plastic bags destroy evidence. Plastic bags are big no-nos. Kazmar might be able to back me up on this one. Paper bags are what you want to keep all evidence in. And if they refuse transport, they refuse transport. There's not much you can do about it, especially if they're alert and oriented ×4. I don't even really want to read the bottom part of that slide. I'll let you read it. But there are some date rape drugs. You can get roofied. I think it's, I forget. I don't want to speak out of term, but like GHB or something like that. Or I'm sure Kazmar would probably be familiar with that. As far as knowing what the drug is and how it's used on victims, not as saying he would be familiar with it in any other way. But also keep in mind that in rape, there may not be just coitus or forced intercourse. There might actually be objects that have been inserted. And again, it's just not women, it's also men. Patient assessment. We'll blow through this really quickly because obviously we know about our scene safety and stuff like that. Form your general impression. Airway, breathing, circulation. Get a good history. Try to find out what's the affected system. How to treat them. How often to treat them. Check your interventions. Do your vital signs. Stuff like that. So, scene size up. If it's a gynecologic emergency, you might have to take a little bit extra care and show a little extra compassion. It's not like, hey, we're really sick. Like, okay. You've got an alert and oriented female that's just having some sort of abdominal pain that might be gynecologically related. So you may have to have some more compassion. And again, if you're a man or a male provider, you have no clue what that woman's going through. So my suggestion always is, let's go to the hospital. Let's just go. Form your general impression. If you do have vaginal bleeding, look for shock, which is your pale, cool, diaphoretic, which means real sweaty or moist skin. It's cool to the touch or cold and clammy. You want to put them in the supine position, treat them for shock, cover them with a blanket. If you can try to stop the vaginal bleeding by exterior, okay, because that's what you really need to do, is you need a clot to form. History taking, you can ask when their last menstrual period was. That could be something to consider. If they're under the age of 18, you might want to be a little more coy. You might need to take them and maybe put them in the back of the ambulance, or have your partner take them off to the parents off to get like medical history. Don't look like you're trying to isolate the two or isolate the child, but ask like, hey, listen, I need to know, especially with a teenager, 16, 17 years old, like, hey, listen, is there a chance that you might be pregnant? Have you had unprotected sex? And that'll help with your assessment. But you need to do it in a manner that's not perverted or pervish. So you need to be very professional. This is kind of a sensitive gray area, so be very careful. So you don't want any sexual harassment charges brought up. So be careful. If you can kind of see if they've ever had a past gynecological problem or any issues, especially when they're pregnant. They may have had issues when they were pregnant before. This might not be their first rodeo. They may have been pregnant several times and miscarried, things of that nature. If there's trauma, again, try to see if you can stop the bleeding. I know it's not the most ideal thing, but if you have the patient kind of help hold the pad in place to create a clot, that's what needs to be done. Do your secondary. You can probably do it en route, especially if it is a true emergency, especially if they're pregnant and bleeding. That's definitely not good. Do your vital signs, monitor, put your O2 on as you get into your advanced portion. Start worrying about IVs, fluid resuscitation for shock. Recess every 5 if they're unstable, 15 if they are. Again, head to toe, recheck, try to get a good history out of them. One of the things that you do need to maintain, especially giving a report, when you come into the ER, you may have to give a report at the desk, especially the patient's underage and they don't want their parents to kind of know that they've been having unprotected sex with the boy that they don't like. Whatever. You've got to maintain their privacy. Also, if you're giving a report at the desk, make sure you're kind of talking in a low voice, talking to just the nurse that's receiving the report that's going to be taking care of that patient. If you have any index of suspicion of abuse, you can probably go ahead and state that then and there. Again, if you have the abuser in the room with the patient, you don't want that to happen. And I'm not just talking about boyfriend, girlfriend. I'm talking about parents, grandparents, children, and it could be a husband and wife, and there's abuse and rape. That is all possible. Just because you're married doesn't mean that you are required to perform sex whenever demanded. Again, use a sterile compress. Sterile. Let me go ahead and talk about sterile dressings. Sterile is anything that you have to open. That's what sterile is, because you will have bandages and gauze that are not wrapped. They're just loosely out there, which is fine. You can use them in a pinch. They're great in a hurry. But a sterile dressing has to do with anything that you have to open out of the package. So if you have to take any bandage or dressings out of the package, that's considered sterile. Until you drop it on the floor or touch it with no gloves on, then it's not sterile anymore. So make sure you're wearing gloves and keep a sterile field, which is very difficult to do in an ambulance, but try. That's it, guys. That's your first one. A couple days I'll post the obstetrics, and I'll talk to you then.